Hi, this is a pleasure to be back talking to the LGS Foundation conference, and it's always a pleasure to hear the stories like today and hear what parents have done to help their kids and how it's inspired this great technology to help other people. So kudos to our last speaker for that. And I think all these things come down to making my talk easier, which is a talk about seizures and safety and rescue meds, because it's a practical talk today about how to create a seizure action plan. So these lights are awesome because I can barely see, but just how many people have a seizure action plan or have had a doctor talk to them about it? Is that? Yeah, how many people don't? Anybody? Or is this a pretty up-to-date crowd? You know, that's great. So we'll talk a little bit about how, in general, how some people aren't as well served or given that information, and how our special needs populations benefit from seizure action plans even more. I am going to speak about seizure rescue medications. I have spoken on behalf of UCB and Neurelis, which makes some of the medicines for this. I've also, like many of our speakers, have other relationships with pharma companies, but I've made sure today's talk doesn't promote any product and should not have any conflicts. So I'm going to discuss the relevance and prevalence of the burden of seizure clusters or repetitive seizures, review the various terms used because they are not uniform. There are multiple ways people refer to this: breakthrough seizures or clustering seizures or repetitive seizures or, pre-status. People have their own ways of determining for their child what this is. And highlight the fact that seizure clusters are a type of seizure emergency and have consequences if left untreated. And we're going to discuss the types of medicines and also how to design a program a little bit, and how patients with special needs like LGS and developmental epileptic encephalopathies are different and may require a little more focused plan. So epilepsy has about, almost 500,000 people affected who are children. And of that, 50,000 are roughly LGS, and maybe another 20,000 could overlap LGS as a form of a developmental genetic encephalopathy like Dravet's and other subgroups. Sometimes they're linked and sometimes they're not. But about 70,000 people have this type of epilepsy. And of course, we've talked about the age of onset being 3 to 5 and different clinical types of seizures for different patients in the LGS community. But all these seizures can have breakthrough events. Some people more generalized seizures, some more tonic or atonic seizures, some absence seizures. And status epilepticus can evolve from repetitive seizure breakthroughs and can have major comorbidity, as you've heard. And SUDEP, we heard some numbers today already in more detail, but I like to think of it as roughly at least 1 in 1,000 to 3,000 people being affected. So if there's 70,000 LGS people, that might be 15 to 20 people with potential SUDEP at any one time in statistics. So if it's, it sounds small, but it can add up pretty quickly if it's you. It's pretty serious if it's you, it's 100%. So these numbers are nice, but what does it really mean? We try to avoid death from epilepsy, and that's what our goal is. So defining seizure clusters, and repetitive seizures, I like to think of it as a type of seizure that's occurring more frequently on a given time period than would normally occur. So when you're dealing with LGS, which could have 100 seizures a week or 200 seizures a week of different types, if you're at 400 seizures a week, that might be a significant change. For someone else, 150 seizures might be a significant change. So only you can define that with your physician and your family member, what you consider a significant change from their baseline. These are not continuous. It doesn't necessarily, in between these events, they go back to normal. They're not just constantly seizing, which would be status epilepticus, either clinically or subclinically. And they can be convulsive or non-convulsive. And because they vary with seizure types, there's going to be a range of when you're going to intervene to treat as a parent, but there are some basically defined time periods which we like to see people intervening by. Usually a standard is 5 minutes, because most seizures that are convulsive, unless they're multiple, like 10, 20, 30 tonic seizures or atonic seizures over 30 minutes, is different than a tonic-clonic seizure over 5 minutes. One may treat those after 10 or 20 minutes if they're atonic, clustering and being more frequent, versus a convulsive seizure you want to treat within 5 minutes. So you have to define what the seizure is when you're going to treat as well. The other thing that people don't understand is breakthrough seizures can occur, and by the time you give a medicine, whether it be a oral, rectal, or nasal medicine or IV medicine, the seizure may have already stopped if it's a convulsive seizure, because they may last 2 to 3 minutes max, sometimes 5. And yes, in our special needs population, some people would have a 10 or 20-minute seizure, or they know if they have 1 or 2 seizures, they're going to go into status, okay? It's a different population with DEE or Lennox-Gastaut. However, most convulsive seizures stop. So when you give that rescue medicine when you're above your threshold for what you tolerate, it's really preventing seizures from reoccurring in the next 12 to 24 hours. That's the way they're studied by the FDA. That's the way the trials are designed. So we're giving these medicines not to stop that seizure you just saw, because it probably already stopped, but to prevent the next seizure from happening. And I think that's very important, because people say, you know, I gave the medicine, it didn't stop for another 2 minutes. Yeah, but did you have another one in the next 12 hours is the right question. So if you ask the right question, you can tell if the medicines are working. If you ask the wrong question, then you think the medicines didn't work. So it's very important that you understand when we talk about as physicians to you, did the seizure medicine work? It's did the seizures keep happening after you gave it, not that seizure that made you give it, okay? So that's very important to communicate that way. And if you have status epilepticus, that's when these seizures keep happening more and more and more, getting closer and closer together. And as you can see from this next slide, the red is sort of an increasing level of severity, and seizures can progress, and people who have clustering do tend to have repetitive seizures, do tend to have more episodes of status epilepticus. And the sooner you prevent those next clusters of seizures from happening, the less likely you are to proceed into status epilepticus. And the risk is statistically significant. If you have these breakthrough seizures, you're more likely to go into status epilepticus at a statistical finding of like 0.002, which is quite significant statistically. So what triggers these events? Well, the most common thing is missing medication doses, or spitting out the medicine, or not taking it, or being sick with the flu and throwing up, or having diarrhea where you don't absorb your medicine. Teenagers who don't have Lennox-Gastaut, or people who use alcohol or recreational drugs, synthetic marijuana. THC is proconvulsive, even though CBD may be beneficial for epilepsy. And so what happens is certain drug interactions can trigger a seizure, alcohol use, sleep deprivation, and of course environmental factors like flashing lights for certain types of photosensitive epilepsy, startle epilepsies where people may have an atonic seizure or startle tonic seizure with sounds or noises called hyperexplexy, or certain seizures triggered like that. And then certain activities may trigger seizures, change in temperature, swimming, getting too hot in a hot shower. For certain people, it can cause vasovagal fainting, which mimics a seizure, or it could cause a seizure. And then there's family things, stress, child being more stressed, sleep deprived, having a fever. And of course, for female patients, menstrual cycles and ovulation are very much a pattern that you may see. A lot of our Lennox-Gastaut or developmental epileptic encephalopathy patients, when they have their menstrual cycle, parents will say, oh yeah, they had seizures, but it almost always correlates with that. And again, having a good seizure tracking device or a seizure calendar on paper, anything that you know when their seizures are, helps us understand if there's a relationship there. And you can actually medicate differently around those cycles to prevent those problems. So why rescue our Lennox-Gastaut and developmental epileptic encephalopathy patients more important than, say, someone with a occasional seizure? It's because these patients have seizures sometimes on a daily or multiple times a week basis. They can sometimes have it nocturnally every night. They can sometimes have seizures rarely during the day. So a flare-up during the day for that patient might be a significant finding. Someone who's sick or having a fever, if they have seizures, they might aspirate and get pneumonia more easily if they're sick. And then varying seizure types can depend, if you're having drop attacks and absence seizures, sometimes one's controlled and one isn't, and then you start to lose control of the one that was controlled. That could be a significant event. So, you want to know what your baseline number of seizures are, and that's where that great data can come in handy. Tracking is, what's a true flare-up for your child? Everybody has a bad day or a bad hour or whatever, but in Lennox-Gastaut, sometimes, if you know your patient well, there's a threshold you get used to, which is maybe so many seizures a week or so many seizures a day, and if there's a significant change above that threshold, that you should probably be doing something to think about a rescue medication. So, if you know when your patient or your family member has days where they have one seizure, they're going to have a second one when this happens, or they know around their menstrual cycle if they have one seizure, they're going to have a second seizure, then those are patients also that you're going to want to make a specific, data entry in your mind and in your plan to intervene at those times. So I talked about the triggering events. Oh, I guess I went backwards, sorry. All right, so we know that Lennox-Gastaut is more likely to have breakthrough seizures. They're more likely to have status epilepticus. They're more likely to fall with their seizures and therefore have more chance of injury, which could also lead to more hospital visits for concussion, broken tooth, broken bone, etc. They're also more likely to aspirate, and that could lead to hospitalizations and ER visits as well. They can be more sensitive to fevers, so if they do get sick, that will also trigger their seizures more as well. So we want to prevent seizures to prevent pneumonia, to prevent aspiration, to prevent all these other factors. It also disrupts their sleep, which sleep deprivation is another trigger. So we want to make sure we nip these in the bud, and that's where rescue medications may be useful in our population. And we can see, this is a slide that I borrowed because it was so nice from Elaine Worrell, that developmental epileptic encephalopathies, 65% will have seizures that cluster greater than 10 minutes, especially in Dravet syndrome, especially with fever, and then Lennox-Gastaut syndrome is pretty high up. So, 60 to 80%, 70% in those cases. And then other potassium channelopathies and PCDH19 and GABR3B, all these patient type of genetics encephalopathic epilepsies will have increased seizure clusters and emergencies. Now, some patients say when my patient does have a seizure, when my child does have a seizure, they go 10 minutes or 20 minutes. And so you want to prevent that and give that rescue medicine maybe a little sooner, because if they go 5 minutes, they're going to go 10 or 20, but if I get it at 1 or 2 minutes, they seem to stop sooner. That's where those acute medicines may be useful to get in as early as possible. But it's still going to take 10 to 20 minutes to fully be effective, and sometimes a little longer. Now also, the patients, if you've heard today, one of the favorite medications for Lennox-Gastaut and Dravet syndrome and some of these other epileptic encephalopathies include things like Klonopin or clobazam or Onfi. Those medications are benzodiazepines related to most of what the rescue medicines are. They're usually something like Valium or Ativan or Klonopin in one form or another, or midazolam, which is Versed, which is another benzodiazepine. Those are our most common treatments, either orally, nasally, rectally. And those medications are still effective in all the studies when given, but because your family member may have a higher tolerance to them, you might need to give a bigger dose to break their particular seizures versus a patient who has a rare seizure and is not on everyday benzodiazepines. Also, the dosages may be higher because if you give the standard dose that most pediatricians or FDA recommendation guidelines say, you need to work with your doctor specifically to see if your patient, if they don't stop with the seizure meds or seizures still happen despite giving them, in the next 12 hours, you might need a higher dose because your body may metabolize it more quickly. So those are things you can only do on an individual basis, or perhaps if you're tracking your clusters on a diary device or a paper diary, you can say, you know what, if we only give this dose, they have seizures 8 hours later. If we give this dose, they don't have seizures 8 hours later. And that's something you and your doctor can work to design your individual plan. So it's really important if you're on chronic benzodiazepines to make sure your child doesn't need more. And that's an individual to individual variation based on metabolism and other drugs and what type of seizures you have. So there are different medication options that exist. There are nasal spray options that have come out in the last year, year and a half. There are two, currently there's a new inhaled one coming out as well. These are based on Versed, diazepam or Valium, and also aprazolam, which is also known as Xanax, which is rapidly acting. That's not out yet, but should be out soon. Now, oral agents are things where people just take an extra medication orally because the seizures have stopped. They're taking the medicine to prevent the next one, and it's safe for that patient to orally take something because they're not going to choke or aspirate or bite you when you try and put something in when they're in a post-ictal or post-seizure state. And then there's the traditional rectal Valium gel, which has up till now been the gold standard, although the nasal spray Valium does seem to have even better bioavailability more consistently for most patients studied in the FDA trials. So those are all options. There's also G-tube options of crushing tablets or giving a liquid version of a rescue medicine. But again, those are going to get absorbed more slowly than the nasal or rectal versions because they have to go through the GI tract, and the same with oral. So again, you're not giving a medicine that's going to act immediately. It's to prevent the next set of seizures when we talk about rescue medication and how they really work. So again, benzodiazepines, which is the family of Valium, Versed, Ativan, which is lorazepam, Klonopin or clonazepam, all those medicines are benzodiazepines, and what we use to work at the GABA receptor, which is one of our main inhibitory neurotransmitters. And FDA has approved 2 routes of administration and different products. One is a diazepam rectal and a diazepam intranasal and a midazolam intranasal right now. Now, these are some pictures. The syringe-like device is the rectal gel, and then you can see a person holding their hands. But I got one from each company, and here's the nice thing. They look exactly alike because they're made by the same supplier, okay? So these things, they're very simple. They have samples out there at their display tables. Each company has them out there. And you just push a button. What's nice about this is you just put it in the nostril, and they don't have to breathe in, they don't have to tilt their head back, they don't have to be conscious to have this get absorbed through their nasal mucosa. Just like the rectal gel, they don't have to be awake or aware to do it. So for someone in a school setting where rectal gels in my state of California had a big political battle at the state senate and legislature because they didn't want the school teachers giving it, only school nurses, it became a big political battle. But in reality, it delayed care. And so now having another route besides rectal, especially in an age of cell phones and people worried about their privacy and embarrassment socially, having a nasal option or other options is nice to have for some of our patients, where in the past, the only FDA-approved product was rectal. So I still have patients who prefer the rectal. I still have patients who prefer the nasal. So it's an individual choice that you guys can talk about with your doctors. But it's nice to know. See how nice this is to carry around and use? The rectal one's easy to use too. It's just, you can have one in your purse to have if you travel, things like that. But it's a lot easier to give a nasal spray, in my opinion, for most patients. The only thing is some are not approved below a certain age. So it's 6 and above for the Valium nasal spray, and it's 12 and above right now for the midazolam nasal spray. So talk to your doctor about what would be best for you. And then the rectal is approved from, age infancy on, basically. So those are your choices based on that type of method. That doesn't mean that oral isn't available to prevent the next seizure. It doesn't mean that G-tube isn't an option. I'm just giving you your different options. It really doesn't matter what you choose as long as it works for your child. So logic wins every time. If you have a plan, it's always better than no plan. And that goes in life in general, but especially when it comes to seizure rescue. And what's interesting, when they looked at quality of life questions and questionnaires and research about what patient families felt, 72% of patients who were cognitive enough to answer about seizures in general, and then 84% of caregivers, which would apply to you guys who are parents here, worry about when the next seizure is going to happen. I think we heard over and over from our parents who've spoken today how the fear of a seizure and how it affects your life, aspiration, hospitalization, all that stuff is so worrisome. However, when they've done studies of how many people had a rescue plan, and we're not talking Lennox-Gastaut families, but in general, 20% of adults and only 45% of pediatric patients had a rescue plan. Now, I try to make it an issue with all of our patients who have recurrent seizures to have a rescue plan. So I was a little surprised it was that low, but not everybody's taken care of by an epileptologist or a neurologist, so it's very important to make sure, if you haven't heard about this from your doctor, to maybe bring up the conversation and discuss this as well. And the benefits are that parents who have a rescue plan are less likely to have worry. They're more likely to know what medication their child takes every day. There's so many patients I see who do not know what medication their child takes. And there's also more likely to be compliant with medications and make sure you take them. Because if you have a rescue plan and you know your child has breakthrough seizures and you don't want that, you're more likely to take your medicines. And you're more likely to know where the rescue medicine is. Is it in the cabinet? Is it in my purse? Is it in the glove box? Is it at school? having a plan allows you to plan ahead and make sure you know where all those things are. And there's statistical data from research that you're less likely to visit an emergency room, call for an ambulance, or end up in the hospital. So logic wins every time when you have a plan. So this just shows you in the research that's been done, in 543 adult patients who aren't Lennox-Gastaut, you can only imagine it would probably only look better with our population, that if you have a rescue medication plan, you're going to be less likely to go into status epilepticus, very significant, and then less likely to visit the emergency room and less likely to go in the hospital. So all these things are very important for Lennox-Gastaut patients especially. And so the average rescue medicine can be given within 5 to 10 minutes, as we talked about. It'll be effective within 20 to 40, and it's going to prevent the next seizure for 12 to 24 hours. In the 15 studies that have looked at 2,000 some epilepsy patients, the average time to treatment calling emergency services is over 42 minutes by the time the emergency ambulance gets there on average, and by the time they get to the emergency room. And the average time to get to the hospital is 56 minutes. So you're delaying treatment for almost 45 minutes to an hour by not having a rescue medicine or plan at home. So, you know, this is another reason to have a plan. So again, defining what type of seizures your child you'd consider a breakthrough or increased worrisome pattern, identifying when that patient is most at risk, at sleep, at school, or at home, and then having a plan for those environments and educating family, caregivers, teachers, school nurse, whatever, when and how to use the rescue medication. And we know that having on-hand rescue medications help, but not everybody utilizes them every time. I know I have patients that I ask them at our visits, did you have to use your rescue medicine? At every visit I ask, did you have to use your rescue medicine? That tells me two things. They have the rescue medicine, and number two, it tells me whether my seizure control is going well enough where they feel comfortable that they don't have to. Now, for some patients, they know if they have a short seizure once in a while around their menstrual cycle, they may not go into status, and they may not go into clusters, and you know, maybe they didn't give it if it stopped after 2 minutes. And then other patients, they have, you know, they have 3 or 4 in a row, and I guess they didn't communicate that, you know, we're all fallible with communication, myself included, that the seizure lasted 2 minutes, it didn't last 5 minutes, so I didn't give it because the paper said 5 minutes, okay? So they didn't understand that in your child, if you have more than one, which I often explain, but people don't always hear at every visit, that if you have more than one seizure in a certain amount of time also, that might be your trigger, even if each seizure is short. Because often atonic seizures are less than a minute, but if you have 5 or 6 in a row, you may want to give a treatment. But some parents get confused, and it's easy to get confused when you hear so much from doctors. And we're not perfect in our communication, and this is a good feedback for me when this happens, because it means I have to do a better job communicating, is just because a seizure happens more often, you can still give a rescue med even if it doesn't last 3 or 5 minutes, okay? So again, you talk to your doctor about this, or your team, and you decide, you know, when's it appropriate for me to use it? Is it 3 minutes? Is it 5 minutes? Is it 5 seizures in a row? Because normally after 3 I worry, and should I wait till 5, or should I give it after 3, or 1 seizure I should worry? And those are things that your doctor can help you figure out. And keeping a tracking record of how many seizures your child normally has and what they look like is important too. Also, whenever you change a medicine, if you have to use the rescue medicine more, then you should let the doctor know this change isn't working, you know? And so it gives you a way to know how to track that as well. So it's really important to have an updated seizure action plan. I recommend doing it at least every 6 months. Talk to your family and say, are we doing good with this plan? Is it still applicable? Has he grown? Does he need a bigger dose of his rescue medicine? Let's say someone grew 10 pounds in the last year, or 5 pounds. Do they need a higher dose? Ask your doctor, because they might. Have they had other medicine changes? Are they on a higher dose of Onfi every day? Should we see if he's on the right dose of rescue medicine? Those are things to ask. And so it's not a one-size-fits-all thing. It's not a permanent, you make one and you're done. This is something like you do every year. You do your IEP every year for education. You do your rescue plan every semester for safety. And also understand and make sure people know how to use the medicines. They're pretty simple, but it does help to review. And make sure they haven't expired. You know, people say, oh my gosh, it was expired, so I didn't use it. You know, usually if it's a few weeks expired, it's probably still okay, but it's always good to check. what the date these things expire, so you make sure you get a refill so you're not stuck without your rescue medicine. And what to do if it fails. When do you call 911 if you do use a rescue medicine? Hopefully you won't have to, but when do you give up giving rescue medicines and actually go to the hospital? Because we don't want people getting overdosed on their rescue medicine either. So clear communications are important for all to prevent misconceptions or challenges, like I said, misunderstandings that could lead to underuse of the medicine or using it incorrectly. And have a form that you use. There's paper forms, there's online forms, like we just heard about Seizure Tracker. I like the Epilepsy Foundation online form. It's easy to get access to and download. It makes sense for most people. Some schools provide their own rescue forms for every different school district, depending where you live. And so make sure you have all those forms appropriately filled out, and prepare anybody to know where the medicines are if they need them, just like you should know where your fire extinguisher is, So anyway, know the basic facts about your seizure plan. Gaps are, caregivers should know what medicines am I on every day, and those type of issues. Is he sick or not sick? Is it near their menstrual cycle or not? Those are all things to help the emergency team or the doctors or yourselves know whether to worry or not about something. And then know the times that the medications are regularly given to your child, like did you miss a dose? Were you late on a dose? What could be an explanation for these breakthroughs? And again, this is a team job. The doctor can't do it alone. You can't do it alone. The school can't do it alone. You have to do this as a team with everybody. And make a good relationship with your doctors to talk about this. And if you haven't talked about it, I'd encourage you to do so. And, kind of let your doctor know the medicines are working or they're not if you do utilize them. And if you find out you're using them more, please let the doctor know, because he may have to adjust your other regular medicines if that's happening, especially if we don't have a cause, like you missed a dose or they're sick with a fever, something like that. And then, again, focal seizures might require a different plan than a generalized seizure. Absence seizures might require something different. And again, know your seizure first aid if you don't have that as well. How to protect their airway, how to protect their breathing, how to lay them down so they don't fall and get hurt. And know what your child's seizures look like, which I'm sure most of the people in this room are experts at that. So this is an example of a seizure action plan that you can get off the web from the Epilepsy Society. We saw an example from Seizure Tracker. There's not a bad action plan. You can make them good or bad based on whether you use them and how much data you put in them. But again, make them bullet point, easy to use by a recipe to follow for an emergency. So in summary, know what seizure clustering and acute repetitive seizures and breakthrough seizures are for your child. Understand the importance and benefit of a seizure action plan and rescue medication. Define what it means to your child and when a caregiver needs to recognize there's a change. And communicate with your doctor if there's an increase in seizures so we can see if the regular medications aren't working anymore, or if there's some other cause going on, like coming down with an illness or something like that. And then empower yourself so that you know how to manage this and feel confident. There's a definite benefit to your stress level by having these action plans in place. We know that from research. And, this helps you better understand your child's needs and medications, and will make you a better educated care provider and maybe a less stressed out parent or family member, which is what our ultimate goal hopefully is. So again, this is a very pragmatic talk. It's a very logical talk. I don't think I'm preaching to the choir probably, but I think it's so important. I love this subject because it is something we can actually do today to help someone's life be better. So thank you for listening, and I'll take any questions. There's a hand there, I see. I have 1 minute. So.
No, you're good. You're good. Right there.
Thank you, Dr. Chez, for being here today. So I have an epileptologist in another state, and I take my daughter to see him every couple of months, totally worth the trip. And so after each appointment, we go over our seizure action plan just to make sure it's just as it should be. If we need to tweak it, we do. What happened is, she'd gone into status or whatever. We had to go to the emergency room at the Children's Hospital in our local city and ended up being on the neurology floor. And the floor neurologist wasn't listening to me. and I said, we have a seizure action plan, and she needs rescue meds, she needs intervention. And he wouldn't do it because he was using old school textbook definition of what clusters were. And her epileptologist and I in the other state had defined our own definition of clusters, and it required intervention. So I'm afraid this could easily happen again, where I butt heads with a floor neurologist who's not her epileptologist, and he wasn't willing to communicate with the epileptologist or look at my seizure action plan. So what's your advice? How can I better advocate for intervention?
Yeah, that's a tough question, and I think it's great that you found a doctor that you are willing to travel to that gives you all that great support. The trouble is, like you said, it's a local thing. I've prescribed doses for Lennox-Gastaut patients that are higher than what the typical pharmacist sees for kids with, say, benign focal epilepsy. And I get calls like, are you sure you want to give this high a dose? It's like, yes, because it's, the thing about oral and nasal and rectal diazepam, it's not like IV. It doesn't rise fast enough to cause breathing suppression, and you can tolerate a higher dose. Whereas an IV, it might be 0.1 or so per kilo, 0.2 per kilo. You can go 0.5 to 1 per kilo of diazepam rectally or orally or nasally if you absolutely have to in a patient who's used to those medicines and can tolerate it, and you have proof from previous examples that that dose is correct. So I guess what I would do in your case is maybe see if there's an ICU doctor or your pediatrician or someone else who could override in the local hospital, meet with your intensive care, because that's where you're going to probably end up if you're in a children's hospital. I don't know if that's at your local, but maybe meet with the head of intensive care and explain who you see, and maybe if the neurologist isn't willing to do it, the intensivist could manage the status and use your action plan and talk to the neurologist for you, or have your pediatrician intervene. Hopefully the local neurologist would listen to a referring pediatrician who sends him business to, modify his attitude. And have him sit down. I mean, what if he's afraid and isn't willing to talk to, maybe find, depending on the age of your child, another epileptologist or a doctor in town. And again, every community's, I don't like to talk bad about anybody, and maybe the doctor has a valid reason I don't understand or you don't understand. So I would definitely, talk to someone else in the hospital, your pediatrician, or like at our hospital, we have hospitalists, we have intensive care people in our community, who see these patients first often and have to administer rescue plans in the ICU. So, we have a team of consulting neurologists. Maybe they could ask someone else to see you when you're in. But again, in your community, there may be limitations. So do the best you can with that. And again, maybe have the doctors in the hospital call your epileptologist on-call person in another state to say, that's who manages our seizures. Could you call them for the plan,
Great.
But
thank you. I know that Dr. Chez, you'll be around for a little bit. You'll be with us for dinner.
And I'll be around at the reception if someone wants to ask me a quick question.
So if you guys have more questions, but let's give him a round of applause.
Okay.
Thank you.
Thanks.
Thanks.